In PT school, we're taught to be movement pessimists. Let me explain. We're told what's the right way of moving, what's the ideal posture. We're taught to find all these movement dysfunctions and all these altered movement patterns that occur. Rounded shoulders, hyperextended backs, pronation, knee valgus, you name it. The list goes on. We're told to never let your knees go past your toes during a squat and to never let your knees come together. Don't get me wrong, because this approach has its benefits. We become really good at finding faults. We become movement experts. We become very good at identifying any deviations from the norm. And that's how we've established ourselves as movement specialists in healthcare. But there are also cons to this treatment philosophy. And it has a potential to do more harm than good. Because we become the movement police. We become too quick to tell patients what's wrong with them. Ooh, your right shoulder blade's not moving properly, it's too rounded forward. Your hips are uneven, your back is a little rotated, you have a longer leg. We as clinicians begin to fear faulty movement. And inevitably, that fear will transfer onto our patients. This article looked at the influence of PT beliefs and how it influenced clinical practice. It says high levels of fear avoidance beliefs in healthcare professionals has been shown to be associated with high levels of fear avoidance beliefs in their patients. Reinforcement of a cautionary and passive approach from treating physiotherapists may lead to long-term passivity, unhelpful beliefs about activity, and disengagement from patient-focused self-management approach. So a scared clinician makes a scared patient. And in certain patient populations, this might increase anxiety, and as a result, patients reduce their activity levels, which is exactly the opposite of what we want to do. It's only a natural response because as a patient, if a clinician tells you to never bend your back in this way, you'll probably remember that and never bend your back again because now you view your body as fragile. Ooh, I shouldn't bend this way or else I'm gonna hurt my back. My PT told me that. I think this happens in PT all the time because in the real world, there's so much human variability. What works for one person may not work for the other. Maybe walking duck-footed is a normal part of human variability and does not need to be correct. Maybe having excessive pronation or lower arches is another part of human variability. The same goes for knocked knees or a shoulder being higher than the other shoulder. And people have been squatting with their knees over their toes since the beginning of time. Especially in many Eastern cultures, the deep squat is a resting position. People have their knees going way past their toes, but you don't see an epidemic of meniscal issues. People just don't move through life with ideal movement patterns. I mean, do you? It's infeasible to ask that of anyone, especially your patients. Here's what happens. Faulty movement becomes the scapegoat for all pain and symptoms. Because if you can find something faulty and deviating from the norm, in everybody, it becomes hard to explain why one person experiences pain and symptoms and the other doesn't. Based on all the research that has been done on pain, we know that pain is multifactorial and there's no one magic bullet that cures pain. What works for one might not work for the other person. I think instead of being a movement police and blaming the faulty movements, it's far more important to become movement optimists. Because quite frankly, we just don't know why, if two people are both moving faultily, why one presents with symptoms, one doesn't. But personally, I think it always comes back to load management. Whether it be physical load or mental load, something happened that caused this manifestation of pain and symptoms. The load, whether physical or mental, has exceeded the capacity of your body to adapt. To put it simply, if it's physical load, your body may just get pissed off when you ask it to do things that it's not used to doing. Like it's probably not wise to go run a marathon without any proper training. And you'll probably increase the chance of you getting injured. But here's the thing, it might not always be physical load. What if a patient is going through a hard time in their life? They're stressed at work, they're not sleeping well, because these things can definitely play a role in the presentation of pain. This article looked at the relationship between chronic stress and pain, and it says, exaggerated or recurrent negative cognitions, rumination or worry, magnification, and helplessness are all maladaptive, catastrophizing responses to pain and non-pain related stress that may prolong cortisol secretion. And as a result, there may be a compensatory downregulation of receptors, so you can get stuck in this state of chronic inflammation and pain. It really depends. There's no one-size-fits-all solution. It really depends on the context of the patient. A powerlifter is complaining of knee pain when squatting heavy loads versus a 70-year-old grandma who complains of pain when going downstairs versus an office worker who has been stressed at work, not sleeping well, and has an onset of non-specific back pain. These are all people with very different stories and different contexts. I think it's about finding the lowest hanging fruit, whether if it's education on sleep hygiene or finding the right exercise dosage. There's no one answer. When it comes to correcting technique, I think unless there's something blatantly wrong that's correlated to symptoms, I wouldn't be quick to ban the movement. Instead of saying don't do this or you'll insert negative consequence, like saying don't bend your spine or you'll get back pain, or don't look down all the time or you'll get neck pain. Don't let your knees cave in or else you get knee pain. I think a better alternative would be to encourage other movement strategies. Maybe try saying, let's try this other movement strategy temporarily to let your symptoms calm down. Because banning movements may cause fear and anxiety. I think ultimately the goal is to modify symptoms and offer alternative movement strategies until symptoms calm down. And once that happens, people are free to move in whatever ways they want. Because we know that people don't move in ideal ways all the time. Be more optimistic when it comes to movement. Give patients the autonomy and the freedom to move. As always, let me know what you think. If you like this type of content, subscribe, and there's more to come.